welcome. We'll do some very quick opening notes and reminders. We have decided as a democratic process here to skip introductions, even though it goes against the Echo model. We all know each other pretty well at this point, at least most of us. And B, really just out of honor for the time needed to do service to the didactic, the conversation, and the cases. So in today's didactic, we are so fortunate to have Dr. Seth Keller talk about decline in adults with intellectual and developmental disabilities and concerns about dementia in a population with so much need. And really, really fortunate to have you here today, Dr. Keller. The other thing, this day and age, we don't need to say too much about Zoom, although if you do have multiple folks at your site, if you could enter all the attendee names in the chat, that would be great, so we can keep track of CME, CNE, of course, muting your microphone if you're not speaking, and practicing saying your name when you unmute, again, as we get to know each other. If you can, great to have your video on, see your lovely faces, and again, continue to get to know each other. We always do our best to protect PHI and being mindful of our conversation around that too, just to not disclose anything that could identify patients or family members. We are recording this session as we do with all. They live on our website and are freely accessible and available. And as always, you will get our 1-minute post-session survey. And those have been so important as we continue to iterate this to make it the best community of learners possible. So please do fill that out when you get it. We have some changes in our upcoming schedule. We've confirmed a few things. We've consolidated a couple things, and we have decided to give you the gift of time on August 12th. That was a TBD, and we made an executive decision yesterday to give you that Friday off. If there's anyone who is upset and distraught at not having Echo on the 12th, we might reconsider, but as of right now, we'll skip that one and enjoy your time. Always interested in cases, and have heard recently that sometimes people have a feeling that their case is not important or complex enough, or it's kind of just a standard clinical issue. And oh my gosh, that is always welcome. And we learn so much from every case and every discussion. And we all go through similar issues in our clinical practices. So no case is too small, no case is too complex. So please do reach out to Allison. We have CME, CNE. We have no disclosures for any of our speaker or planners today. Same for nursing. This is a good reminder from Allison that the addresses have been shared. Keep an eye out for an email from the UW CME office. It may go to your spam folder or junk mail. And we'll double back with you. If you don't hear anything from them, get in touch with us. Again, we're going to skip introductions, but here you are across the state of Washington in our various locations. What a wonderful group of providers with diverse practices and so much expertise. Here's our hub team. I want to say a welcome to Tristan, who is taking over on the IT side, and he is at the bottom here. I also want to do a special shout out to one of our hub team members for whom it is their birthday, I believe today. I'm going to give you a second to guess who that might be. You can put it in the chat if you want. Or just maybe cogitate about who it may be before I reveal it to be the esteemed Dr. Parsi. Happy birthday. I think today is the day, yeah?
Today is the day, 29 again. It's amazing.
Wow, fantastic. And as much as I would be concerned that you are working during your birthday, I'm glad you're sharing part of it with us, and really appreciate you so much as an esteemed member of this group. So happy birthday. Okay, and with that, I will turn it over to our presenter today, Dr. Seth Keller, who is a tireless champion for adults with intellectual and developmental disabilities, both on the national and international stage. He is a practicing board-certified neurologist at Neurology Associates of South Jersey, past president of the American Academy of Developmental Medicine and Dentistry, co-president of a current national task group, and past chair of the adult IDD section of AAN. and really just doing wonderful work, improving the diagnosis and care of individuals with intellectual developmental disabilities as they age. So I will turn it over to you and stop sharing here.
Thank you, thank you, thank you, thank you. Boy, you guys are a fun group. I'm telling you, we got birthdays, you're chatting. This is group. This is really cool. I appreciate being and happy birthday. Yeah, it's really great being here. I feel like I'm with friends. I've actually been with the University of Washington, and as Christopher, you were kind of talking about this several years ago when I was with the my ADMD meeting. We work with Special Olympics. So we had this, as you guys may know, back in 2018, Special Olympics had their national games in Seattle, and I took advantage the opportunity to hook up with the neurology department back then and gave grand round. So it's great. And I do frequently visit your state. So I definitely I'm happy to be here, whether it's even by virtual or otherwise. So let's, for the interest of time, I'm just going to get right into what it is that I want to talk about. And one thing that's not really covered by my topical area is I had just gotten back from Ukraine. So I'm going to be giving you all a little journey of my trip to Ukraine. I got back on the 12th of June. I'll explain that because is my trip to Ukraine is somewhat salient, I guess, to this the topical area a little bit, but not quite exactly. And I'm actually thrilled to be here as part of an Echo session. As I was mentioning before we started the official call, I've actually been an Echo Hub member myself in various states related to aging and dementia. And I do specialize, aside from my work in developmental disabilities, I do specialize in neurotypical populations of aging and dementia. So what you do, what you see, what you think about, this is kind of what I dig too, and I definitely care about that. But what I've done over the course of my many years in career, and Alice, you're asking me, like, why did I get into this field? It was a good question. So basically, I've kind of gone into an area of a niche of a population of those with intellectual and developmental disabilities. And this would be people that you may think of that have, say, Down syndrome or cerebral palsy or autism or anywhere in between. And I focus on their neurologic complication in those with adults. Epilepsy is actually a big part of what I do. But also over the course of years, what became obvious is this population is aging, and with age comes for concerns of change and decline, as I'm going to be speaking about in the next time period here, is really a big deal about aging in the developmental population as compared to all of us on the call who may not have a developmental disabilities, as what does that really mean? And then certainly in the developmental population, not just aging in some kind of aspects of decline, but is it possible that the decline that they're showing signs of, is it dementia? So I'm going to be kind of going into that. And I think what I'm going to do is I'm going to preface my presentation based around a case and get your minds kind of wrapped around. I wouldn't say this is an exact specific case, but it kind of emulates a case that I know of quite well that I present in Project Echoes. So this would be basically a 45-year-old woman who has Down syndrome, and she has a known history of thyroid dysfunction and mood dysfunction. And her family, for the most part, has been very concerned about her that the last, say, around 6 months or so in home, being very forgetful and having to remind things to her. And she also has a day job. I mean, COVID was somewhat challenging for her, but she has a day job. And so her work was concerned that that this woman was having problems. And this, I don't know if presenting a case on a 45-year-old woman was as unusual for Project Echo, but in those with developmental disabilities, and it'll be very relevant for this case in particular, early aging in the developmental population and showing sign decline is not so unusual. So 45 years old, again, it may not be typical for a lot of the didactics or echoes and other general dementia, but it's definitely there. In the background of this woman, she lives with her father. She's lived there her whole life with her father, and she has a younger sister. And just like many siblings, her sister has been very supportive as a sister. I mean, it's like sisters often are. She doesn't live with the sister, but she's very, very supportive. And that level of support has been more increasing over some period of time, especially with these so-called changes. She's on medication. She's on Synthroid for her thyroid dysfunction, and her thyroid levels basically are normal. She's also on Zoloft for mood dysfunction. And the concern basically, or the question is this possibly early onset Alzheimer's? So that's basically the general case. And what I'm going to do is, as I'm going to present this didactic, I'm going to come back to this case and pick up on this case and see if I'll see if I taught anything, if you learned anything. How have I helped in my presentation that gives you food for thought that maybe what this could be? And that's kind of my intention. Well, people with a developmental disability, this is kind of my demographic slide, are aging like the rest of the world. The one thing I left out in my presentation is a US-based demographics, how the United States, like other parts of the world, are getting older, living longer. And I kind of left this out for this presentation just to save a little bit of time. But basically, people with intellectual and developmental disabilities, just like the rest of the world, just like the United States, are growing older. And those in particular that might be over 40 to 6 years old is going up and up and up. And by estimates by 2030, we're going to have a lot of people, over 1 million plus, growing in the United States. So people are getting older, they're sticking around longer, and surprise, surprise, with age comes changes that we all think about, especially in this group that we're talking about with dementia. I wanted to add this slide that really talks about, this is really more of a socially oriented slide that talks about, and it's a little busy, but I wanted to give us some sense about it, is that people with intellectual and developmental disabilities back 20, 30, 40, 60, 100 years ago, tragically, sadly, unfortunately, really didn't live very long. And in the background of those photographs, there's these little lines. There's a black line, there's like an R or a pink line. The black line represents intellectual and developmental disabilities on average, and then the one that's kind of in pink line represents the age. So people over years with general nature of intellectual and developmental disability are living longer and longer and longer, and people with a Down syndrome in particular are living longer, but they're not living as long as the general population. And on top of the lines of that I showed you are these little pictures, and those little pictures basically represents, I guess I can call it, some of the social mores of our country. What was our country going through at the time? So you might not be able to see it to the very far bottom around the 1920s and 1930s, the eugenics movement. You might be appreciative or knowledgeable about eugenics. I mean, I'm being kind of facetious in my God bless the United States and the purity that people in the United States, a proportion of people in the United States felt the purity of humanity and genetics, all that if you weren't pure of bread and all that, then basically, I was going to say a piece of shit. They didn't quite say it back then, but they basically really were saying that. And it had a lot to do with, who was a better person and who was not a good person. And those that were had intellectual and developmental disabilities. And that certainly wasn't the word that they were using back then. Morons, feeble-minded, idiots was the official names that were often provided for this population. They certainly weren't thought as anywhere equal to other people. And at the time, back in that time period, the intellectual developmental disability population, if they lived long enough, which they didn't, often were living in state-run institutions. And that's what the other little pictures are. These are photographs from back in the day of people living in large institutions, including across the United States, whether it's Washington State or where I'm at, New Jersey. It was really part of the normal way that this population lived. And then over the course of decades, going from the 1960s with, at that point, John F. Kennedy and his own sister, Rose Kennedy, that had a form of a developmental disability. He himself was really very prominent in raising the awareness of this population to have more value. And then the formation of the ARC, ARC, which is that little picture above John F. Kennedy in that photograph, the National Association, they called it Retarded Children. Now it's called the ARC, ARC. They changed the acronym or the name of it. Do you guys know Willowbrook and Geraldo Rivera? So Geraldo Rivera got his claim to fame. This is this picture of little Geraldo back there in 1972, I believe, in Staten Island. He went in the middle of the night with a film crew in this facility called Willowbrook. Willowbrook was a state facility in Staten Island, New York, where he basically was led in by a physician, Mike Wilkins, to kind of shine a light on abuse and neglect. And it got out there and it made Geraldo Rivera very famous, and it became a national headliner for a while, leading ultimately to lawsuits and closure of Willowbrook. And it really led to a number of proclamations around the United States about values of people with developmental disabilities and living in institutions, living in the community. Special Olympics are on the same time period from a family advocacy standpoint, American Disability Act, And then it really led into a whole growth of a lot of advocacy groups. So be it as it may, what this really meant on the slide really means that people live longer when you care for them. I mean, that's basically what it cares. So if you care for someone, and I mean it, when you care for them and you're giving them care and support, it's going to matter in how they live. There was a Closing the Gap. Some of you may not have heard of it. It was David Satcher, the Surgeon General of the United States, back in 2000, brought together a lot of thought leaders around the country, and it really recognized there's a huge amount of health disparities for the developmental population. And my own professional organization, aside from the American Academy of Neurology, the ADMD, was born out of that. So my own group, the ADMD, was formed by my own colleagues who were there at that meeting and said, we got to make a change. We got to change. We got to get practitioners to get involved. So really the issue in mores have changed quite a bit. This slide goes into the issues of again, I know you guys talk about dementia in your own echoes, and this is really just a slide that talks about, I won't go into all the issues of it. It's like what's normal, you know. So we all know that as we age, there's a lot of things that happen to all of us. I'm 6 years old, so I can say I got this, I got this, I got this. It's like a Chinese menu. I got all these things. I don't want them. My hair, my eyes, my hearing. You know, these are things that happen. So obviously, you've got to really know what's normal or not to be able to understand what's abnormal. So really, just the nature of these expected physical changes is really inherent. The challenge is always that in people with intellectual and developmental disabilities, it's rhetorical comment, what's really normal for them? Like when they age, what's normal for them? So when people do come in with decline, and this is just this slide that talks about functional decline, and this is kind of I'll say this is the differential diagnosis that for me as a general neurologist or a developmental neurologist would say someone's coming in and they're not right. They're not acting right. They're not moving right. They're concerned about a change or decline. So this is really a differential diagnosis that I look at and say, well, why? Why are they declining without me jumping to the diagnosis of dementia? Is it really a primary cognitive dysfunction? Are they often different because it's sensory, hearing, vision, neuropathy? Are they not moving right or getting around because it's really more of a neuromuscular type of problem? Or is it a purely mental health problem like psychiatric? Or is it really perhaps a general medical issue that can be predominantly be from maybe their heart or their lungs, or maybe it's complications from medications like adverse drug reactions? So I think this is just the wide way in which not just people with developmental disability, by anyone coming in and say, you're showing sign of decline, why? These are things that have to be thought out in our differential in terms of working them up. Well, people with intellectual and developmental disabilities have certain age-related issues that are kind of salient that we think about in the world of developmental disabilities. And I'll be focusing on Down syndrome in just a moment here. People with Down syndrome have a high rate of sleep disturbances, hearing loss, visual change, weight difficulty, thyroid dysfunction, sleep apnea, and definitely seizure disorders are more prevalent in this population, but I'll be focusing on early onset Alzheimer's. People with cerebral palsy, motor dysfunction, they also have health-related issues as they age, increasing pain, increasing problems with swallowing, a lot of oral health problems, and they definitely can progress in terms of their motor dysfunction, leading to further compromise in their functionality, often related to spinal disease, bone loss, bladder bowel problems, and then also autism, which is a heterogeneous population, also might have its own nuances of age-related change. But autism being somewhat of a heterogeneous population, it's hard to really know for sure what one person with autism may expect when they're older from someone else with autism, because they might be having their autism from other reasons. Someone from autism might have it for, say, Rett syndrome, or someone from autism may have it for Down syndrome, or someone may have autism for another reason. So sometimes it's hard to always compare someone with autism generally and say, oh, they all get this and they all get that, because you don't really know what's driving it or what's the underlying neurodevelopmental problem that causes autism. I just bring it up, but it's not that easy. I'm going to focus really a lot on Down syndrome. Not that it's easier, but it's actually more of a concern in terms of their aging, because they do age, seem to age kind of quickly. So when age occurs or when change occurs in people with Down syndrome in particular, it's a question of, is it is it normal? Is it really normal? And I think the one thing that's very important, and there's some, like really wonderful, pretty great photographs of people around the bottom here of different ages of someone with Down syndrome, is what's called life stories. And what's very important about the life stories is really to understand who they are and who were they and what do they do. That's really the life story, the narrative, whether or not it's by a story or by photographs or video, to really know what they were really like. And I think really challenging for us as healthcare providers, for me as a neurologist, is often when I see someone in my clinic who's already showed signs of a change or decline, I don't know what they were 5 or 10 years ago. So you don't really know what they were because you never saw them then. And you might go into a certain biases of what maybe they were always like this. You don't really know. The other important part is really know what are their health comorbidities. I mentioned on the previous slide that maybe they got thyroid dysfunction and maybe they got vitamin dysfunction, maybe they got sleep apnea. So you got to know those things. And then definitely the psychosocial changes in someone with anyone, whether it's Down syndrome or not. And the psychosocial changes is really more of the issues of the changes in their life. I mean, that would be for all of us in the transitioning of life that we've all go through, from living at home and growing up and going to school, getting married or not, working or not. People with Down syndrome in particular are extremely sensitive to changes in their environment. Families getting older, a parent dying, jobs not working out, COVID. I'm restricted in my program because COVID happened. So there's a lot of nuances that are very relevant to ask questions about. And then of course, dementia and early onset Alzheimer's, which I'll talk about. And then on top of this is really is being very careful about the underlying biases, stereotypes, and the term diagnostic overshadow. I'm not sure if that's a common term that you guys in your world hear about or use, but we use that term quite a bit in developmental disabilities. And diagnostic overshadowing basically is a term used for basically a quick assumption or a bias that someone that has developmental disability, that their change that's happening that you hear or see about is because they got autism or they got Down syndrome or cerebral palsy, rather than thinking there's something untoward going on underlying the problem. Like maybe they got a real problem, maybe they got really dementia. So diagnostic overshadowing again is an implicit, a quick to judge kind of situation, and we use the term that a lot when we think about this. So in changes in people with Down syndrome, cognitive change in particular is always concerning. And I kind of mentioned about life stories, but who is this person and what do they do and who are they? And so definitely understanding about them in their life is so important to do. And that information will come from the family member, the caregiver, the person with them. One aspect of cognitive change that I just threw out there is called regression. And there is this called regression in Down syndrome that happens, and it's very actually quite dramatic. It happens usually in someone in their late teens or 20s with Down syndrome, or maybe 30. And basically they rapidly over the course of weeks, months, and a year, basically almost become catatonic, really catatonic, where they become almost nonverbal and non-functional. And it's a real huge regression. And I wanted to lay that out there as that's something very, 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 very different than early onset Alzheimer's. So regression is a lot of etiology to propose about what that is. There's tests that try to look for the cause, but be it as it may, I'm not going to focus on regression in this presentation. It's really different. So the other issue of cognitive change could be the medical reason I already mentioned. In some of the differential diagnosis of cognitive change, maybe it's sleep apnea, maybe it's vitamin deficiency, maybe it's B12 or thyroid. Psychological, psychosocial issues of change could be inherent about it, or maybe they're just normal aging. But then the issue is it mild cognitive impairment, or is it actually early onset Alzheimer's, which is what I'm going to focus on the next few slides. And the data, the demographics of early onset Alzheimer's really is as high as 60% by age 60. And it just goes up and up and up after that. So this is a slide that you're all familiar with, is, what are the types of cognitive change that we see in anyone? Is it normal? Is it MCI? Is it dementia? Is it a delirium, type of delirium, or is it form of depression? And I'm not going to kind of bore you with this kind of overview, because this is something that I'm sure that in your hub team and what you're discussing, your people that you see, this is what we think about. We think about, is it this, is it that, or is it in combination? And it's not that much different in people with Down syndrome, but it might be a little more challenging to parse that out. And how do we sort this out? I mean, what do we really do to kind of sort out, you know, how we figure out the change in this person? And I'm beating the band here by keep saying life story, life story, life story. So I'm kind of redundant in some of my comments here, but there is a differential diagnosis that really has to be appreciated. You need to do your blood test. You need to look for sleep apnea. You need to do a whole psychosocial evaluation for them. You look at their medication list. You have to look at their neuromuscular status to see if the change isn't really from a neuromuscular standpoint. But that definitely, as we all know, is there's a psychological assessment, a cognitive assessment. The challenge with cognitive assessments is the typical prototypical cognitive assessment that we think of in our population of neurotypical people is very different. And I'm going to talk about that in a little bit. Imaging, I'm going to mention about that, and then I'm going to talk a little bit about biomarkers. So in the groups that I work with, and I have a little QR code, I thought it was going to be kind of cool. And if you want to scan it, I have some like links. It's kind of my neat thing, music technology that now can scan. If you want to see the QR code, this goes to this instrument that we in my organization, the NTG, use. It's called the Early Detection Screen for Dementia. And basically what it is, this is an informant-based tool filled out by caregivers. And it would be by the group home, by the family members. They fill it out. And basically what it is in essence is it's an ADL. How well does this individual perform in their activity daily living now as compared to, say, a year ago? And it's basically almost like, did they change or not in the last year? Yes, it's almost like a yes or no. And what this tool really does, it starts the beginning of an official dialogue that maybe change has really occurred when a number of these checks are provided. Yes, they change. Something's happening to this person. And therefore, once this form is filled out, the person then brought to the healthcare provider, and their healthcare provider would say, "Oh my gosh, you're right, it's changing," and they would do the workup. This tool is not specifically used to make any diagnosis at all. It's basically almost like an early warning sign. If you can think about it that way, it's early warning. And this tool, the NTG EDSD, is based on an assessment tool that has been used. I'm going to my next slide, called the D-SQUID. And this is, I'll kind of circle this over here, DSQIID. This is basically more of a diagnostic tool performed by psychologists called the Dementia Screening Questionnaire for people with intellectual and developmental disabilities. It came out by one of our colleagues in England, Shlomo Deb. And we worked with him, and he helped develop this tool. And this is really more of a tool that helps to be a neuropsychological assessment for the developmental population. And the reason why these assessment tools are more nuanced for developmental disabilities, as you might appreciate, is because people with a intellectual and developmental disabilities, because of either cognitive or verbal abilities, may or may not perform your typical, tools that we use in our typical population of people to be able to figure it out. So we had to develop certain tools that are more diagnostic for developmental population. And I'm really just using a number of these tools, but these are really more that have to be or can be filled out by higher level researchers or psychologists. This is not your typical tool that I myself even use, to be honest with you. So once we do a workup, once we do a differential, and we're trying to pin down that it's not vitamin, it's not hormone, that changes are happening, we're now trying to pin down some more black and white diagnostic tools, and this is kind of where biomarkers come into play. And I would imagine that the issue of biomarkers in any of your echo discussions, I don't know if you ever talk about biomarkers, but definitely biomarkers are going to be here to stay. They're going to be the future of the black and white nature for diagnosing Alzheimer's disease for the most part. And this is just a slide that I kind of copy here, and there's a QR code if you want to go right to the source. It really talks about the usage of a spinal fluid, amyloid markers for beta amyloid or tau over the course of time, from even pre-symptomatic to early or late signs of mild cognitive impairment, and then when signs and you're now officially making the diagnosis. And this is somewhat similar to those with Down syndrome, but this particular biomarker that I'm showing you is really more of a generic one for probably all people with half level of Alzheimer's disease. And I think what you're going to see, I'll just give my quick editorial comment on biomarkers. I think what's going to happen is that even in people with Down syndrome, you're going to actually get diagnoses made before symptoms. You're going to get pre-symptomatic positive Alzheimer's disease when they have no symptoms at all, because all the biomarkers are going to show that you may not have it today, but you're definitely going to get it tomorrow. Therefore, you're going to get it. Therefore, what do we do? So I'm kind of giving you that rhetorical comment. So I really think biomarkers at least for those that are highly suspicious for getting it on their genetics or what have you, are going to be really looking out for these biomarkers to help make decisions, and they may be hopefully therapeutic options if and when they become available. People with Down syndrome, jumping to Alzheimer's and Down syndrome, it's not a coincidence why people with Down syndrome get Alzheimer's disease. It's basically they have an extra chromosome 21, which is basically the marker that leads to the propensity to create the amyloid, the beta amyloid into itself. So chromosome 21 is where this all is made, basically, where the protein product is made. Beta amyloid in small measures is great, normal for a lot of development of a lot of our bodies and cells. But if you have too much of anything, including beta amyloid, it leads to, at least part of it, leads to the neuropathology, which is ultimately Alzheimer's disease, tau protein, neurodegeneration, and women seem to be at higher risk of getting it sooner. But the age of onset, and there's that little graphic on the top, people go up. So I said 60% by age 60. It would be really, really, really rare and uncommon for someone under 40 to get it. So anyone comes in, I say, and they have so-called dementia or Alzheimer's under age 40, I said, I doubt it. I highly doubt it. There's something else usually going on. And the difference also is the rate of decline. So just like a normal typical population, you often need about a 10-year window. Early sign to death is like 10 years. Unfortunately, in people with Down syndrome, it can be anywhere from a few years to 5 years, and they rapidly progress and die. So it's a horrible progression that happens, rapid decline, as mentioned here, often sensory impairment, hearing impairment, and there's actually a very high rate of seizures, myoclonic seizure in particular, that happen during it. So sometimes the heralding of the change of the brain could be seizures. So when someone never had seizures or seizures under control, and they start having seizures in their late 40s or 50s, to me, my radar goes up like, gee, this is really bad news. This is not a good sign. This is a slide that talks about some of the graphics that look at some of the amyloid. It's a little busy slide to the top that shows the comparing someone with Down syndrome to someone who does not have Down syndrome. And it really basically, the essence of the slide really shows that beta amyloid is a huge amount in people with Down syndrome. And on the bottom slide with the graphic, with the bar graph, it shows in this study that came out in 1993 that beta amyloid, even in someone in their 30s, is hugely prevalent in the brain well before symptoms. And as they're going from 30s to 40s to 50s and the 60s, the amount of propensity for the accumulation of beta amyloid in most people with Down syndrome is hugely high. So the issue about a biomarker is very high, but it doesn't say they've got Alzheimer's. So there's going to be a combination of tau biomarkers and percentages that are going to help define it. In the next few slides, and I'm going to kind of end with some of these, is caring for people. And this is a whole topic into itself. What do we do? And certainly you guys in the Echo model here talk about this, I'm sure, all the time. You're presenting a case and they're giving you scenarios. How do you care? You know, obviously caring is a double entendre. You know, you're caring from, yes, we care for them clinically, but it's caring for them with empathy and sensitivity. The therapeutics, certainly as me as a neurologist, I have cognitive enhancing drugs like we think about in anybody. And really the data is very sparse in using the donepezils and the galantamines and the memantines and the like. There really is not a lot of great supportive literature, even though it's marginal support. But it's really probably a lot of behavioral care and support. There's just like it is in normal typical people with Alzheimer's disease, people with Alzheimer's and Down syndrome also have a huge difficulty with affective problems, like also with anxiety and depression and psychotic features. So they too are also often having problems, wandering, hoarding, inappropriate behaviors, sleep dysfunction, very difficult. But definitely health and wellness can never be forgotten about. And again, I can speak a lot about that because I think it's so important to really appreciate that, you know, life is not over, though it is very challenging for many people. And then dealing with the associated health complications that come along the way, seizures, sleep dysfunction, gait dysfunction, swallowing dysfunction. And then, like everything with Alzheimer's, anticipating the progression and the issue about when palliative care and end-stage support should be begun. But there's also opportunities for research in the field of Alzheimer's and Down syndrome. There's the financial and legal aspects of family supports and putting a trust aside. And then the issue of transitioning of care often dealing with the people that are younger to older to even geriatrics. So transitioning is also a big issue. But I can't really speak enough about the impact on families, because in many people that we're talking about, so if you have a 40, like this woman that I talked about, who has this Jones assignment, I'm going to come back to this case, family, I mean, her father, she lives with the father, her sister's involved in all these things that her family's going through. They're feeling very horrible about what their loved one's going through, and all these emotions that any family or carer go through is not unique to people with Down syndrome. But think about someone who has a lifelong intellectual developmental disability, who's always been supported, who's always been, we need to help them. We got to care for this person, because if we don't care for them, no one else will. And we got to make sure they live up to their best potential. And they're doing this throughout their whole life. So they're almost like on fire all the time, caring about this person. And oh my God, now they're showing decline after all these years, when we thought we just got it right for them. Now they're showing decline. And then you're talking about the sibling or family member who they themselves are older. So think about it. You have a 45-year-old person with a dad, and think about the dad. The dad is probably in his 70s or early 80s, and he too is having his own issues. So in resources, we also give a lot of resources to families and other organizations. There's a QR code also that talks about what should family members know, what for advocates know. And there's a QR code that has little booklets for people that want to know about aging and Down syndrome and Alzheimer's and Down syndrome. And there's one guide that we worked with an organization in Rhode Island a number of years ago. It's a community guide, what the communities need to know about what they should look out to help their people with developmental disabilities that might have issues of aging. This one slide talking about some current research around the United States. It's called the ABC studies. And this is basically looking at some of the demographics of people aging with Down syndrome. They're doing biomarker studies in this population. And there's a listing of the number of universities around the country and somewhat around the world that are doing some of this work. And I do have some patients and some colleagues that are working in these different centers to try to understand more about what this really means. This is definitely a partnership. So here we are in Project Echo, here talking about this as a partnership, I think. Yes, sir, it is. So basically when it comes for this population, we have a whole slew of different people and different organizations that are there to help people with developmental disabilities. I'm part of the ADMD, the NTG. We have a lot of organizations which are not that much different, but in the world of developmental disabilities, we have our own groups. So back to the case, and I just want to kind of finish with this case, and then I'll jump on my Ukraine story and we can go around for some discussion. Well, I think the backstory, and I'm going to give, this is kind of really the backstory. The woman who they're concerned about, her mother died a year ago. And so basically, this is kind of the kicker to the story. I'm kind of saving the best story for last here. So what happened is she lived at home. She lives at home with her mom and dad, and her mother, God bless her mother, tragically had developed cancer and died. And so when she died, as anyone could imagine what happened to her, she got very upset, obviously, because this was her world. Her mother was her world, God bless her father. And then the sister, her young sister, then basically almost like moved in to almost become the mother to her. So she actually almost became like the mother. Instead of like your sister, this is my sister, we're like hanging out as sister. She almost like assumed the parent role over her own sister. And this is when the change happened. So in the face of the decline and the changes of what they're happening, this is basically what it is. So in this conversation, I'm giving you like the punchline here. So as I'm listening to this, and this is a real case that I dealt with a few years ago, I'm listening to the story, they brought it in, and I said, well, tell me more about your story, what's going on? And they started telling me, oh, my mom died, and this is what happened. And they basically all started crying. They all started crying and they said, oh my God, and it's all because of her difficulty, not because she's got Alzheimer's disease at all. It's because she's having a hard time. The whole family's having a hard time of adapting and dealing with this. And the daughter who's showing decline, she's depressed, she's anxious, she's upset, she's having an adjustment difficulty. So basically, what's the next assessment? What's the next care? Is it possible that underlying all this, to me, an obvious psychosocial issue could be Alzheimer's and starting? Sure. I mean, can you do the work of an evaluation? Certainly it could. But basically what I did is I spent my time talking about psychosocial support and listening and talking. And so this became more of a psychosocial conversation, more than you got early onset Alzheimer's, you're now going to have rapid decline, you're going to now have X, Y, and Z. So my conversation, honestly, so I'm basically, I don't know if this will surprise anyone by this conversation, maybe I fooled all of you. Basically, this is not a case of Alzheimer's. This is a case of like a false positive or something like that. This is not really what it is. However, basically on a lot of cases, we do see this quite a bit in someone even this age or older, and they're not going through psychosocial changes, and the differential diagnosis is ultimately leading to it. So that's basically my case on either end sandwich, an overview. So maybe I'll stop right there, but I have a few slides. I'm just going to go over my Ukraine trip. So I could stop right there and maybe throw it out there if you guys have some questions. Allison, what do you think? Should I just keep going, or you're muted? What should I do?
I would say keep going. And while you're going, people can be pondering questions that they might have. I think that it's amazing so far. So keep it rolling.
I have you all on the edge of your seats, right?
Yeah.
You're like your mouths are hanging open, like you don't know what to say, right?
I do see a question for Patricia Weber. She's got her hand up.
Hi, Patricia.
Well, hi. I'm so glad to hear this talk. Number one, I'm immediately curious about your trip to the Ukraine and how you arranged that and how that worked. And number two, I'm a physician at one of our state residential institutions. And I'm always curious about how others, I'm familiar with our.
Are you at Furcrest? Your Furcrest?
I am, yes.
Right. So yeah, actually, Patricia, just to let you know, you and I share that in common. I'm also a physician at the ICFs in New Jersey. So I know Furcrest, not exactly because I've never really been there, but the state facilities that I work with in New Jersey, New Lisbon Developmental Center, Vineland Developmental Center, Hunter Developmental Center, basically in every way, shape, and form are very similar to what I understand Furcrest to be.
Oh, because when I grew up in New Jersey, so
okay.
I know there was a center near between Pennington and Princeton, which when I looked it up had closed, and I wasn't sure about other centers in New Jersey.
Yeah, last time I checked, there's 6 large facilities. Because of COVID, I've actually not been there for 2 years, but I'm the neurologist, or had been the neurologist at least New Lisbon Developmental Center, 1914. I think Furcrest is not as old as that, but you guys
no, about 1958, I think.
Right. Yeah, and Vineland Developmental Center is like 1880 something. I think that's what that was. So this is basically so in the developmental centers, and this will be a segue probably to my trip to Ukraine, truthfully, because that's kind of relevant to my trip. But anyway, I cut you short. What was your question? I apologize.
Well, no, that's what I wanted to. I wanted to hear more of your opinion, more about the trip. And while I'm on, I'll just extend an invitation. You're more than welcome anytime you're in Seattle to come visit Furcrest.
I would be pleased. And really, just as a backstory, my own personal journey in developmental disabilities is basically working at facilities like Furcrest, to be frankly. So basically, I've been doing this for many years, and so part of my private practice in New Jersey was serving the developmental center, New Lisbon Developmental Center, since 1997, and like Furcrest. So my own appreciation of knowledge of developmental disabilities was kind of focused on institutional care and institutional living and blah, blah, blah. So my own bubble of my world was basically centered in institutionalized care, but I've kind of become, over the last number of decades, become more about families and communities and social issues, blah, blah, blah. Not that you can't have that, certainly, institution. So that basically framed even my own visit to Ukraine. But I'm going to talk, I certainly want to talk about that. And so as I go through my maybe chatting about what I did in Ukraine, and Barack, I see that you too have a question. Barack Esther, I see you had a question.
Yeah, thanks so much. That was really sort of thought-provoking, really interesting. And I guess I'm kind of curious. You know, we all struggle with how complex advanced care planning and sort of, discussions of goals of care is in dementia in general. But then I can imagine, just wondering if you had like thoughts or tips or perspectives on sort of the specific population of people with Down syndrome and Alzheimer's disease.
Well, it's similar, but it's not similar. I mean, right now, when you think about it, the comparison is like, so when I treat my quote unquote patient with Alzheimer's disease, am I really just treating the patient or am I treating the family? So I really think that's kind of how I look at it. So who's the family? Who's the caregivers of those with the Down syndrome or, another developmental disability who has dementia? And I think that's really it is. So when you treat them and you're assessing them, you're caring for them, it's a matter of appreciating their own nuances that might not be equal to, say, someone that is our prototypical person with Alzheimer's disease who doesn't have a developmental disability is a different. So for instance, someone like at an institution, like you were mentioning at Furcrest, how does that matter if they're living in an institution in terms of how you support the person and the caregivers at an institution? How do you support the person if they're living in a group home? So I use that in some of a rhetorical comment. I want you to think about that. What's the implications? What do you do? Do you treat that person, that patient differently when they're supported by another group or layer that they too are affected by this person who's changing, as we all know? So and when they're changing, change affects everyone else, right? The domino effect. And so sometimes the change can have huge implications upon the other people. And just say in a group or an institution, what does that mean for the other people living in the group home? What does that mean for other family members? What does that mean anywhere? And so I think you have to appreciate it. And I became more socially oriented. In my brain as a neurologist, I definitely became more socially conscious about these things. That even though I wouldn't say I'm formally trained in psychology or social services, but I think over the course of years, I think I definitely became more appreciative of community services and social services and working together with other people that need to support the person. And it isn't only about that person with dementia. That may not answer your question in particular in terms of planning and caregiving, but definitely once you label that person as having Alzheimer's disease, you're setting that person up with the reality that this is a progressive disease that's terminal. So therefore, it's as dark and foreboding as that may be, it's really the nature of giving that information early on in terms of decision making early on and planning early on, financial or otherwise. And I think that that's the right thing to do. The challenge, I think, for a lot of people psychologically is really being not certain about the diagnosis and being nervous about it. Like, is it really Alzheimer's? Is it really dementia? I'm not sure. Is it mild cognitive impairment? I really think some of the uncertainties, my own philosophy about it, the uncertainty of the diagnosis probably doesn't allow people, doctors and others, to really be that black and white because they're not really certain unless you're an expert in the field and you can be certain about it. But the biomarkers that are going to be out there, I think, will be more certain. And once you have a diagnosis, you can really plan these things out. So, and there was another question. Is it Francie?
Franja. The spelling doesn't help so much there. Thanks, Dr. Kelly. As you're talking, a lot of what you're sharing, it sounds like kind of a shared decision-making model in helping to create a good plan of care for your patients.
Yeah.
And I'm wondering, when you do find cognitive impairment that is likely going to be progressive, how do you involve the patient and to kind of do that balance of optimizing kind of their autonomy and determining goals of care and not adding to kind of the emotional distress? Is it any different than a neurotypical patient?
No, it's a great. I mean, it's really great perspective because even explaining the word memory or explaining the term dementia, like even explaining the diagnosis out of respect for the individual with dementia, you want to explain it. Out of respect for them, out of due diligence, you want to explain to them. So even the concept, which are somewhat metaphorical, I guess, in some way. Do they really understand? So sometimes you even explain the word, like, are you having memory problems? Are you noticing a change? It's almost like I hate to never say when I talk to them like a child, but try to really use simple word to explain it. But as we know that in people that not only have an intellectual disability or certainly have dementia, their own ability to process or understand is difficult. And so I, like anyone else, when someone's sitting there, I want to look them in the eyes. I want to be them and have an active participant. I don't want to treat them like like a fly on the wall or a potted plant. It's not right. It's not appropriate. But it does become very difficult when the person themselves is not able to understand or interact, and it's naturally a difficult challenge. And so I want to be very careful about the words that I use and don't make assumptions about what they can or cannot appreciate, because I don't want to upset anyone. I want to be very sensitive to these words, and that's just I guess it's an art, I guess you can say, on how anyone communicates with someone and knowing that person on how well they can understand the words that you use when you're talking about them. But certainly because they already have a baseline intellectual disability and someone with Down syndrome, and then on top of that they're developing a dementing illness, there's no doubt that it is becoming more and more difficult to speak with them and direct with them in terms of the plan, the attention, and certainly care planning, as you're describing, and shared decision making is really working with the other family members or caregivers in that shared kind of way to help and support that person to make those important decisions. There's no doubt about that. But I wouldn't say it's that black and white, but it's all built on respect and caring and sensitivity. I'll put it that way. So yeah, Julie, you have a question? I see your hand up.
Well, thank you so much. A comment is I'm very grateful that you gave us the tools that you use for the cognitive evaluation. I think that is a great tool to have in just general practice, to have that list to monitor for changes. I didn't quite catch the link between Down syndrome, dementia, and seizure. Are you saying that patients with Down syndrome and dementia are then more prone towards seizures? Did I catch
Absolutely. No, absolutely. Yeah, basically, I mean, Alzheimer's disease, it's cortical dysfunction, and because the cortex where the damage is being done, all the neurodegeneration, the amyloid, the tau, in some respect, it's a cortical disease. So because and that's where seizures come from. Seizure disorders are stemming from a cortical dysfunction. So there is a very high propensity for people that have neurodegenerative cortically based diseases like Alzheimer's to have an increased risk of seizures. So seizures in particular are very prevalent, more so than normotypical Alzheimer's disease. So those absolutely in Down syndrome have a much, much higher risk of getting seizures that are particularly myoclonic seizures, rapid jerks and all that. So they're bad. So when you see it, you often see a decent percentage of people with Down syndrome with Alzheimer's that have myoclonic seizure. They all of a sudden have jerking extremities, they fall down on the ground, and that into itself can be extremely problematic in terms of a therapeutic for them. So yeah, myoclonic seizures, and absolutely, you got me right. That's exactly right.
Well, so I don't think I was worried. So our neurotypical dementia patients then were prone to, but Down syndrome is even more so?
A lot, absolutely, yeah. People with general normotypical people with Alzheimer's have a higher risk of getting seizures. So for me as a seizure doctor, I see seizures in different populations of people. I see seizures in children and babies because of developmental problems, injuries, and then as people get older, there's a great uptick as people get in their 50s, 60s, 70s, and 80s that have more and more risk of getting seizures. And why do they have more risk of getting seizures when they're older is because of these issues. They could have a stroke, they could have Alzheimer's disease, they could have a head injury. So absolutely people with Alzheimer's do have an increased risk more than just typical people. They do, not just the cognitive decline, but people in particular with Down syndrome have a much higher risk of seizures than general population of Alzheimer's. And that's how I would best put it. Yeah, and then the drugs, and then the drugs that we use, then they're problematic. What drugs do we use for seizures, and what does the drug do to their cognition? And I'm helping this one and then hurting something else. So that then goes to a rabbit hole of side effects and complications, which creates its own nuances. Christine at Furcrest.
Yeah, so I just had not really a comment, but just or not a question, but a comment about what you're talking about, because we do have clients with significant seizure problems. And then it becomes tricky to try to figure out, is the cognitive decline coming because of an Alzheimer or just dementia? Or is it coming from the hypoxia from a long seizure requiring rescue medications or things like that? And so I know that that's questions and conversations we've had on my team with our people with significant epilepsy and other seizure conditions.
Yeah,
So
I mean,
something
I would
else.
say that, yeah, I mean, it's great. I mean, you're right. It's not always black and white. I mean, you got all these reasons like you just described, but definitely I think myoclonic seizures in particular, I mean, that's inherently, that studies show, and I've seen it, it's really Alzheimer's based for Down syndrome. I wouldn't blame it on, hypoxia or, I mean, get head injuries or other prolonged seizures. I mean, yeah, there's no doubt that can complicate the situation. I think the key thing about, and this is kind of the nuances about treating seizures in this population or behavioral in this population, and this is a whole topic, you'll invite me back next time, is how you pharmacologically manage anything. How do you pharmacologically manage someone who already has a developmental disability and they're basically already maybe on a plethora of drugs for various reasons, and now you're trying to pharmacologically measure or treat a problem, and then the drugs themselves are part of the problem, side effects and nuances. So there's really, you have to be so careful. And then from a behavioral standpoint is making that decision of is treating it non-pharmacologically or pharmacologically for behaviors. And that's a topic into itself that deserves a lot more attention than I can probably do on our call. That's a huge important issue.
Very good. I also see a question in the chat from Deborah Tillman. Deborah, do you want to unmute and ask that, or do you want me to read it?
I just wondered if there was a propensity for these folks to remain with their family caregivers, because that caregiving has been going on for their whole life, whether they remain in single family residences with their family members as opposed to going into facilities.
You're talking about after they develop Alzheimer's disease?
Yeah.
Well, honestly, what I would think of it this way: think of any family member that you might know that has, their husband, their wife, whatever, and they're developing Alzheimer's disease. That this is their love. This is who they've been with their whole life, but it's their son or daughter, and this is their love. This is their normal way of living. And what is it that they are going to want to do? I don't know if I hope you can get where I'm going with this one. I would like to hope that they would like to continue to care for that person despite the inherent challenges that they have. They're older, they got their own issues. And I think that's really the sad story that happens when you see the situation playing out, that they're trying to care. It's really, to me, there's a lot of tragedies, sad stories, emotions that go on. The last thing they want to do is really put their person in a long-term care facility after, caring for their loved one and fighting for this person their whole life, putting them to another person, a group home or others who they don't know and they don't trust and they don't know with safety, and they're worried about it. Believe me, those kind of emotions run deep. And so for I'm sure you guys know the concept of aging in place. You guys talk about aging in place all the time. Right, aging in place. I mean, aging in place. Aging in place, you're trying to provide keeping at home. You want to bring in more services to be able to provide for that loved one who's going through dementia. And that's the same thing with people with Down syndrome or anything else. But it's a matter of, can you do it? Is there a practical reality, finances and support and the needs? And to me, the issue of aging in place is always there. And I've been doing this for a lot of years, and I just can go on and on and on, and all the stories about it and the heartbreak and the emotions about, can you do it, can you not do it? And then even in a group home, if they're in a group home for their life, how does the group home even deal with the changes? Because the group home is it's just like an institution. I mean, it has certain rules and regulations, and when things are out of kilter, I want to speak for Ferncrest, but basically when things are out of sort, it kind of like affect everybody. It's like a monkey wrench into things, like, the thing, oh my God, you're changing things. It affects this person. It affects staffing and training And so it really creates a whole domino effect when these changes happen to people. And so for us treating them, I think it's important to appreciate the big picture, and almost like you need a whole like a multidisciplinary approach to really understand the implications, because it's not really just that me as a neurologist to kind of say, oh, give them more donepezil or giving them, you know, a behavioral management medication. Is what's the implications psychologically or socially. It requires a lot of that understanding. So it's pretty heavy. It's a lot.
Yeah, I really appreciate too that kind of knowing the person's story. It's, you know, as a neuropsychologist, we get asked to do evaluations on individuals with, you know, either intellectual or developmental disabilities, and without a prior baseline, it's hard to detect change. And that person's story really becomes the baseline. So
You have to know the story. Yeah,
Right.
yeah. I mean, that's everything. So let me tell you about can I tell you about my Ukraine trip? You ready to hear about my trip?
absolutely.
Okay. All right. So basically, I went to Ukraine, and this is my slide here, and I have a few slides. June 3rd through the 12th. And as you probably can tell, I'm very passionate about what I do. I hope you know that. I care about the developmental population. I've been doing this for a lot of years, and really I've been blessed. I mean, honestly, I pinch myself. I've been really blessed because I've been doing this nationally in the United States at a very high level of leadership in terms of my own field as a top leader in developmental disabilities and neurology. But I've also got a reputation internationally as well, and so I'm out there a bit. So I was invited to go to Ukraine by this particular organization on the slide called Disability Rights International. And I do work internationally in some regards. I do presentations and webinars, but I haven't really done like gone into the right into the facilities and really see it firsthand. And what DRI really is, it's basically a watchdog organization that basically what they do globally is shine a very bright light with a loud megaphone, and they're basically wanting the world to know that there's abuse and neglect in certain parts of the world with this population, mainly within institutions. The culture of the Soviet era and in Eastern Bloc countries, including Ukraine and Russia and all the countries in that area, they basically, their model, just like the United States was a lot of years ago and still is like it is with, you know, like Furcrest and New Lisbon and other facilities, they basically, that's it. They basically, from day of birth, someone's born with a decent, bad developmental disability. They don't have anybody in the community to care for them. They've got no early intervention. And they basically put it into their culture mindset that this is the way people are living. I mean, honestly, I'm going to just be moralistic about it. I can't help myself. So basically, that's basically what's set into this area of that's what it is. And I think the tragedy upon tragedy is that in the institutions, and I'm going to show you some slides on this one, is that they're basically not really caring for them. And it's basically warehousing. They're warehousing people, and there's no early intervention. There's no, so for instance, if someone has swallowing dysfunction on day 1, or hydrocephalus from day 2, or significant cerebral palsy, motor dysfunction, you're dead. I mean, I hate to say it like that. You're just not living. So they have a high rate of early death in infancy. And if you're able to survive enough to get into the institution as a baby, because that's really happens, you get there in what are called baby houses. So my part of it was to go as the eyes and ears medically with Disability Rights Organization. And this is the link to them. And I would just kind of just show you what I did. So this is basically, this is a little geography. I didn't know much about Ukraine. I probably knew as much about Ukraine, probably everyone. There's a war in Ukraine, and my God, the Russians are coming in. And I had the flag. I was really glued to the TV when it all happened earlier in the year. I'm Jewish, and my roots as a Jewish person are from Eastern Europe from 100 years ago. So I had some, I guess, connection to Ukraine, but I wouldn't say that I understood about it. So basically I decided to go to be the eyes and ears with DRI. And I got, my wife wasn't totally thrilled with it. I guess she wasn't too happy, but basically I got to believe and know that I was ending up in this small area in the southwest part of Ukraine called Chervenitsi, which I kind of circled here in my Google Doc here. And I flew in out of Newark Airport to Istanbul, Turkey, Bucharest, Romania, which is at the bottom here, and then from there another flight to this town called Suceava, Romania, and that's where my colleague Eric Rosenthal, who's part of DRI, his executive director, we drove basically an hour and a half to the Ukrainian border and set up camp in this town, the city called Chernivtsi. And Chernivtsi is basically it's a metropolitan city. It's not a little hamlet. It's not like really in the rural. It's basically a city. I wouldn't say it's a giant city. They have a university. They've got a lot. I don't know how many thousands of people live in Chernivtsi. And because of its location, it is very far away from the war. So the war, and this is just overlying a slide here. This is basically a slide that I took from a few days ago of where the war is at. So the war is basically far to the east, somewhat on the south. And again, I'm far away. So I knew that I wasn't really in any great danger, but some of the pictures that I show around this picture are ones that I took. There's no doubt that nationalism is all over the place. Flags are flying. You see billboards up there, and even getting into Ukraine was a real bitch. Mile after mile after mile getting into Ukraine was 18-wheeler trucks that were lined up mile after mile because they basically were stopped at the border for security purposes, and they basically is like a snail trying to get across the border. So supplies are horribly low, and gas, forget about getting gas. It's really hard to get around, but you have to like carry like a gas tank. So we actually had these gas tanks in our SUV, and what we did in our journey, we went to a number of these, and basically I hate to use the word Furcrest or New Lisbon, they basically probably could have been like some of the institutions were like the United States, I don't know, 50 years ago, perhaps. I'm just making, I wasn't there 50 years ago, and it might have been like that 50 years ago as a warehousing kind of thing and not treating people. I hate to say it like that. And so what I did is I basically went with this crew, and what you see in some of these slides are some of the pictures that I took. Oh, actually, I took all these pictures. There's some pictures you can see people with cameras. We went with the BBC. So the people that you see with some of the cameras and talking, so we went there with the British Broadcasting Company, who are basically coming out with a documentary on what we all did. They did their part, we did our part, and I was the eyes and ears. And there's some pictures that I took, but some of the pictures that I did not take were those that I just really had a hard time taking. And I'm really even not going to show you, I don't think I put this up there, are pictures of those that were really abuse and neglect. I mean, they really were people that were tied down, people that were emaciated, and there definitely were a percentage of people that were displaced from other institutions from the East where the war is going on. So the stories, and I'm going to show you a story in a minute here. So the percentage of people, so these are state-run institutions. These are people that are put there as children or babies, and they basically don't have any great services, and the war only magnified the problems that they have. But so for me as a physician, I met with some of the medical directors, and actually all the medical directors in each of the facilities I went with, and they actually asked me to review cases. And the cases that they asked me to review were mainly epilepsy. I do treat a lot of epilepsy. They said, oh, I have so-and-so, and here he is, here she is, and they're having this seizures, and they're having this problem, this all through interpreter. And I got to see firsthand about what quality of medical care they're being provided. And it was atrocious. It was shocking to see what they don't do. They don't even have blood. You can't even get a blood test. No blood testing. They don't take people out of the facility, out of the institution. So you don't go to the hospital. There's no scans. There's no blood tests. And the drugs that they have are very limited. They don't have a lot of pharmacologic medication. So they're asking me as an American neurologist, what would I do? And I felt like an ass. I did. I really felt like a jerk in a way because I couldn't even really answer their question because I'm spoiled. I got this drug and I got this drug. I get EEG, I can do a blood level, and and almost like, oh my God, what would I do? And I really felt almost embarrassed. And I'm thinking, well, how would I think in my own world if I was working there? What would I do? But also, what would I think if I was born in Ukraine and I was trained in Ukraine and I had the mentality of Ukrainian culture, who basically people were dying, and basically and I was going to show you all these pictures of early onset Alzheimer's. I was going to show you all these pictures of geriatric patients. Here we are, we're doing echo on aging. Sadly enough, they don't have any seniors. They're dead. They die. They die. All these people are dying by age 35 and 40, aspiration pneumonia, heart failure. So they're put in institutions. They're not given any early intervention. They're not getting any care for any really way. And even the socialization is sad. I mean, it's very, very sad. And this is just a few more pictures. I guess I did show more pictures of showing you. So there's this one guy, that's me with the mask on. And he's basically tied. He basically is tied to his chair, to his bed, and he's got autism. And their solution is time. He's restrained, and that's another guy in a wheelchair. They're restrained. They don't have. That's what they do. They restrain people. And so what I want to show to you, and this is like the last slide, and we can chat. Beside the BBC, and I don't know if you guys know who Richard Engel is. So we had the opportunity, this is just a few weeks ago. So we met with Richard Engel, and this is a QR to this video. Richard Engel, he's the one in the green t-shirt. He's an NBC war correspondent who basically is in Ukraine and in other war fronts by filming the war. He's with big press on his shirt, with a big helmet, and he's like ducking like bullets and all that. It's amazing what he does. And the sad story, the really crazy story about him, about Richard Engel, he has a 6-year-old son with Rett syndrome, which is a rare form of autism. So his son, Henry, and this is kind of adds a whole layer of his own emotion to this. He's very humanitarian, he really is. And so he heard about us doing this mission, and he really wanted to do a story also on this Ukrainian crisis of developmental disabilities. So I'm basically going to show you this video that Richard Engel put on the Today Show, that was on the Today Show, that was just out on the 12th. So I'm going to show you this. Tell me if you can. Can you see this? Do you guys see this?
Not yet.
Okay, let me share. Wait, okay, let me share my screen on this. So I stopped sharing.
While you're doing that, I just want to acknowledge that we are coming up on the 1:30 hour. Or at the time. So if anybody needs to drop off, totally understand. If you are able to hang out, that's fine too. So
yeah, this is I think it's like my last slide. This is only 3 minutes. Okay, do you guys see it now?
Yes.
Okay, I'm sorry. So let's try this again. Let me just make sure I got sound on. All right, I apologize. Here, let me do this one more time. Share. I want to do this here right. Wait a minute. Yeah, it's so we went with Richard Engel. Okay, this is gonna work. Okay, here we go. Share. Okay, I'm going to play this.
Physically and intellectually challenged Ukrainians. They're not really orphans. Nearly everyone here was abandoned. Some of the older ones have been here for decades without a single visit. And now Russia's invasion has made their lives even more difficult. The facility is overcrowded after similar shelters in eastern Ukraine were evacuated out of the path of Russian troops. 2 vital therapy rooms had to be converted into dormitories for 38 new arrivals.
Hello.
Masha just came from the east. She's alert and bone thin, with a trail from tears down her temple.
So this is Roxalana. Hello. I'm going to pull this down a little bit, and you can see really terrible scoliosis, really terrible condition of the body and spine. You okay? Okay. They're so skinny. They're all so skinny.
Without stretching, braces, surgery, or therapy, Roxalana and the others are getting worse. Some appear malnourished. This is not a hospital. They don't do advanced treatments or give much medication.
Hi. You've got such a lovely smile.
The most we could give was attention, touch, and affection. Catherine lit up when I rubbed her hand.
No, you don't want to let me go. I don't want to let you go either.
Many are clearly starving for love and their families.
Mama! For the last several hours, Vlad here has been calling out to his mother. And it's one of the hardest things you can see because a lot of the kids here have been calling out to Mom and Dad. Mama! And they're not coming.
Vlad's parents fled to Germany as refugees, along with his 3 healthy siblings. This war has a dark secret. Many able-bodied children were taken out of Ukraine, while the profoundly disabled were often left behind in shelters like this.
A bad system that neglected kids, that left children to grow up without a family, is now massively overwhelmed.
Eric Rosenthal has studied shelters for the disabled in Ukraine for 30 years.
Every single day a child spends in this facility, they're losing a piece of their life.
The director, Bogdan Kakina, says he had to suspend modernization plans because of Russia's invasion. This damn war set back their development, he says. Victims of a cruel biological fate and an outdated medical system, they are now also victims of a war that has left them more isolated than ever.
Mama!
And because of the invasion, this shelter and others have not only had to forgo any kind of improvement, structural improvements, they've canceled all outside entertainment, all excursions. So what you saw is how they're living all the time. Hoda.
That is so profoundly sad. Thank you, Richard. Oh my gosh. Like, I mean, you see all the horrors of.
So, yeah, I mean, that's basically the essence of it. So let me just turn it off. Yeah, it's sad. It's and that's basically what I saw. I mean, it's you know, I kind of give you this. Look, I apologize. Let me just turn my. Let me just turn that off. Okay, hold on. Anyway, so I mean, that's basically. I mean, that's really, you know, I wanted to share that with you guys, and you know, kind of end on that note. I mean, it's, you know, that's kind of what I saw. So right now, I mean, so now I'm now involved. I have webinars. I'm writing articles, and so I've made you know, however this is going to be in my own personal world. Frankly, folks, I don't really know. I'm trying to decide. I'm trying to get my mind wrapped around my own personal connection. So thank you.
Well, thank you. As a parent, as a human being, it's hard to sit with, you know, but so very much appreciate your work and your advocacy and just the calling that this appears to be for you. So
I appreciate it. Yeah, we all do our part. I think that's how we do our part, whether that's with your children, your parents, your patients, our communities. I mean, isn't it? I mean, I hate to be philosophical on a Friday here, but, you know, we all do our part. And it just, I think anything that I do has really kept me well grounded, honestly. It really is. But, you know, anyway, but thank you all.
Thank you so much.
I appreciate it.
Yes.
So, yeah. So if you want to have me back, if I have updates, I'm sure this is not the end of my journey, nor for what I do. I know it won't be.
I hope it's not, and we would love to have you back. So thank you for that. And thank you also, Karen Clay, for putting some resources in the chat. We'll be sure to distribute those with the rest of this too. So with that, thank you for being with us today, all of you, part of this community. And again, Dr. Keller, thank you so much.
My pleasure. Thank you, guys. All right, guys, have a good weekend again. Thank you so much.
You too.
Bye.
We'll see you in a few
Bye-bye.
weeks otherwise.